Good morning, Dr. Kriegel. How are you? Good. Give me one second. All right. We're just gonna wait for people to come in. Give me one second.
There. Can you hear me? Now, I want to ask for your assistance because I am deliberately technologically ignorant. Okay. I do lots of Zoom things all the time, but I think you guys saw the title that my assistant has. It's the Supreme Commander. Okay, there's a reason for that because she is in charge. I am not. So you guys can be the substitute Supreme Commanders. How's that?
Sounds good. We will do whatever you need us to do.
Okay. If you see something that is going wrong, or if somehow I all of a sudden disappear from the screen or whatever, let me know.
Sounds good.
Do people ask questions during the presentation, or do they just wait till the end, or how do they do that?
Most often they'll wait until the end, but if you want questions to be asked throughout, then we can set it up that way. We can just say it in the beginning, however you would like it to be done.
Well, what do you guys think? What works best for you?
I think questions at the end would be best, just so you have time to get all of your information out
Okay.
and then let people think of their questions and then hold them off until the end. Because I also feel like if we ask throughout, a lot of people won't have anything to ask. They usually take their time to come up with whatever questions they may have.
Okay. Well, good. Well, I can talk for hours, so
Okay.
just be aware of that, and we'll see how it goes. And if I don't know the answers to the questions, I just make them up. So this is a huge, huge topic. So all I have time today is just to kind of give everybody a bit of a taste of it, and I'll explain that when we start. But it's a big deal. Dr. Kemp said that the campus was closed.
Yes, sir. The campus is closed today.
Okay.
Just letting people in slowly, and then we'll give it a couple minutes and then we'll get started.
Okay. Do I see anybody else, or do I just see you guys?
There are other people in here, so you should be, if you go up to your top right corner where it says view, that should give you an option to see more people.
Okay, gallery, is that what I want?
Yes, sir. I believe so.
Oh, cool. All right.
All right.
Okay. Good afternoon, everyone. Uh, we are happy to have you joining us. We are representing the Chronic Pain Management Program. I'm Dr. Gail Kemp. I am the um, principal investigator and project director. I want to welcome everyone who is attending, and I want to give a special thank you to our graduate assistants whose tireless efforts really help us to pull off these wonderful seminars. And so I want to start off just mentioning my appreciation for them. So thank you to Kiana, Bria, and Amir for all of your work with the project. Um, so without further ado, I want to introduce our speaker. Before I do, or as I get ready to do that, let me just note, just put our HRSA disclaimer up, and now I will introduce our speaker today is Dr. Michael L. Kriegel. He is the president of Kriegel and Associates, a consulting firm specializing in the creation and development of interdisciplinary pain management centers. IPM uniquely addresses chronic pain with minimal reliance on opioids. With over 35 years of leadership in the field, Dr. Kriegel has played a pivotal role in the clinical, business, and operational developments of more than 20 IPM centers. And he's currently worked on his 23rd center, the Reiser Institute in Georgia. Kriegel and Associates is the only consulting firm in the U.S. exclusively dedicated to IPM center development, and their expert team of physicians, psychologists, physical therapists, and other healthcare professionals offer guidance for creating high-quality IPM centers. And today, Dr. Kriegel is here to present to us from his vast range of experience working in the field of IPM, and we are excited to have him here today. So I will turn it over to you and welcome Dr. Kriegel.
Thank you. No, I appreciate the opportunity to meet with you today, but I have to start off with full disclosure. I did graduate from Ohio State, so I just need to let everybody know that right off the bat. Um, the wonderful world of pain management is difficult, exciting, scary, fun, and challenging all at the same time. And if you folks have taken time out of your day to be here for this presentation, then you have a wild ride ahead of you if you plan to continue working in this field and to continue growing. Bria, am I supposed to see everybody, or am I supposed to just see Dr. Kemp?
It's up to you, but if you click the view, you can choose how you would like to see them.
Okay, let's try that. There we go. There's everybody. The first thing that I want to try to do is help all of you understand that pain is both a personal experience, but it's also a puzzling experience from all manner of perspectives. And so let me start by reading the definition by the International Association for the Study of Pain. This is recognized as the premier society for the study of pain in the world. Very respected, very intelligent. They've been around since 1979. So I'll read their definition. Pain is defined as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. I don't have clues what that means. Any of you? What does it mean? Okay. Now what? So let me try to help you understand that when you are in the field of pain management, when you have actual patients sitting across from you or lying on a table and they're feeling pain, the best definition of pain is what hurts. Now, I used to be part of the residency program for the South Carolina Medical School. And I used to get these very bright young doctors would come in, and they were all excited, and we would be talking about pain. And what I would do almost immediately was ask each one of them to meet, that they have to answer this question right now. If you had to choose one of two, I would pose this to all of you. If you had to choose one of two things, you had no other option, someone's going to break your arm or someone you're going to die, someone you love is going to die. Okay, what would you choose? Well, all of these doctors, for some reason, chose somebody breaking their arm. Well, now, why would that be? And eventually someone would say, well, because the broken arm doesn't hurt as bad. Okay, so are you telling me that having someone you love die is more painful than nociceptive stimulation, an unpleasant sensory experience? I mean, is that the pain of the loss of a loved one? Is that real? Or is that all in your head? Is that just made up? Is emotional pain more unpleasant than physical pain? Well, I've heard that some pain is good. In fact, there's a statement that you hear all the time about people getting physically fit, and that's no pain, no gain. Well, does that mean pain is good? Sometimes. Maybe, maybe not. Starting to get a clue as to how puzzling this is. What about when a woman has a baby? I hear that hurts. Never had it. Never tried it. Don't think I want to. Women often tell me it's worth it. That having a baby to love makes the pain that you go through worth the birth of the child. You starting to get confused yet? Well, if you are, then you're beginning to understand what it's like to have patients that you are responsible for taking care of, that you have said you're going to help them, and their first point, the first thing that they say is, the doctor, I hurt. I have that every day. I have patients come in and sit in my office, or we work with them in the clinic, and they hurt. Well, how long does pain last? I mean, what does it last forever? Does it last some of the time? I mean, I bumped my elbow earlier today. I felt pain. Interestingly, if I sit in this chair most of the day, I'm going to be stiff and sore when I get up. That's pain. Is it real? Yeah. What are the components of that pain? Here's the real question. Of all the things that I'm going to say to you folks today, this is the part, this question gets to the essence of the sensory experience that we call pain, okay? And that is, what does pain mean? And I ask my clinicians that I train all the time, what does pain mean? And so from the standpoint of the individual, which is how you have to focus, they want to know, what does this pain, what does my pain mean? Well, if I haven't eaten today, what does it mean? I'm hungry. My stomach hurts. Okay. Does it mean I'm going to die? Well, if I don't eat for about 3 or 4 weeks, yeah, maybe. If I sit in this chair all day and my tail hurts from sitting and being inactive, what does that mean? Well, technically it means that my myofascial components of my structure are probably getting insufficient blood flow, and they're not receiving enough oxygen. So therefore, the muscles are becoming depleted, and that's why they're feeling sore and achy. Okay, again, what does that mean? How about it means get up and walk around? How about replenish some of that oxygen? By the way, a quick sidelight. What's the most important component for our survival? Food, water, or oxygen? Well, in actual fact, if you think about it, you can go 3 weeks, 4 weeks without food. You can go about 4 or 5 days without water, and you go about 3 minutes without oxygen. Your brain will die in 3 minutes. So how often do we breathe, and how important is oxygen? Well, what does it mean if I deplete oxygen from various parts of my body? My body may warn me by sending a signal that we would interpret as pain. What organ in the body uses the most oxygen? The brain. Now, here's a rather odd thing. Since the brain uses more oxygen than any other part of the body, what happens if I deplete that oxygen? Well, are you aware that the brain has no sensation? So therefore, if someone comes in, as frequently in my career, with headaches, and they sit down and say, well, doc, my head hurts. Well, what I know it's not is their brain, because the brain has no ability to send sensations or send signals that are pain signals. Have I confused you yet? This is the world I live in. This is what started a long, long time ago. What does pain mean is the real question, okay? For any of you that plan to be in clinical service, you will be faced with that question all the time. And being able to answer that, not only for your patients, but for yourself, at the times when you feel nociceptive stimulation. That's important. And the interpretation of that pain signal is going to vary depending on all kinds of factors. That's why the best perspective of pain is now recognized as the biopsychosocial model. And I think probably most of you have heard of that. If you've been in school long enough, then you've run across what that is. But essentially, it says that the interpretation of pain is what's key, and it is influenced by all manner of aspects of who we are and where we are and how we live and what society we're in, whether we're male or female, and the circumstances that experience of pain is felt. So what makes pain different if it's chronic pain? Well, that's easy. It's chronic. It doesn't go away. Well, now, what does that mean? I have a patient who was working for Duke Power as a foreman, and one of his linemen happens to be up in the the scaffolding working on a wire, and he touched the wrong thing and got electrocuted and set on fire. And my patient went up the scaffolding and got him down. And when he did, he jumped. The man he was holding happened to weigh about 250 pounds, and it destroyed his lumbar spine. So my patient was almost paralyzed, had to go through 14 surgeries, all kinds of vascular problems, myofascial problems, all kinds of things. And that accident occurred 34 years ago. And he has been in chronic pain ever since. So what does his pain mean? It's a tough question. Because what you find is that it gets even more complicated when pain doesn't go away and it affects all aspects of your life. So, you know, if you take a look at the old classic, you know, doc, it hurts me to do this. Well, what do the doctors say? Don't do that. Well, if you don't do that after a while, what happens to your strength, stamina, and range of motion? Kind of a classic problem that occurs from lack of movement is something called a frozen shoulder. elderly women are very prone to it because doing that hurts, so they just don't do that. So after a while, because the shoulder joint is actually stabilized by muscles, it happens to be the only joint in the body that is stabilized by muscles instead of by ligaments. Those muscles will literally bind down and cause that shoulder to become immovable, and it will cause all kinds of pain. So lack of movement is something that is an issue, and people with chronic pain tend to move less, so they get weaker and weaker, have shorter ligaments, shorter tendons, shorter muscles. They also tend to get depressed. If you've ever had pain that lasted for any length of time, it affects your mood. It makes you irritable. It makes you sad. It interferes with your sleep. It interferes with your activities. The fellow that I'm describing to you has been out of work since his injury 34 years ago. That affects his financial situation. That affects his family. That affects his activity level as far as vacations and all kinds of things. So that turns into a process that becomes quite interactive. And so chronic pain is pain that doesn't go away, but it's even harder to interpret because it becomes interactive with what's referred to as comorbidities. If you don't move around much and you don't exercise much, you tend to gain weight. Well, what does that increased weight gain do to the pain? Well, if someone has low back pain, more often than not, it increases their pain. If they don't exercise, those tight muscles will cause more pain. Well, then we get back to that question. Well, what does that more pain mean? And then there's another thing that happens, okay? This is referred to as the vicious cycle of pain. If any of you have been nailing in a nail or something, or doing some kind of work, and you hit your thumb or hit your hand, the common response is to go, oh, like that. Well, a reflex that occurs from pain is muscle guarding. So that muscle guarding is designed to protect our body. And that's great. Works good. But what if the pain doesn't go away? Well, muscles in the area of the discomfort will tend to stay tight. That will cause a depletion of oxygen. We've already said oxygen is vitally important for our survival, and it is also the energy that fuels our body's activity. So those muscles use up oxygen. Anybody ever had a Charlie horse or cramp in their calf muscle? How bad does it hurt? Okay. What's damaged? Nothing. So what's the cause of it? Lack of oxygen. When a muscle spasms, like a Charlie horse or cramp does, that is an insufficient blood flow with insufficient oxygen supply, which causes a muscle spasm. Well, back to our pain causes muscle tension idea. After a while, those muscles that are tight, just because of the pain in that area, they will spasm. Now we have more pain, but we just got done saying that pain causes a reflex of muscle tension. Oh, so that causes more pain, which then causes more muscle tension. But that more tension after a while causes more spasms, which causes more pain, which causes more spasms, which causes more pain. You're starting to get the drift? Yeah, it's a spiral. It's not a circle. And people with chronic pain are very vulnerable to this because their bodies are reacting reflexively to the discomfort that's not going away. Well, now, is that all that happens to this vicious cycle of pain? Well, no, because as the pain increases, it recruits muscles farther and farther from the site of the initial discomfort. So my 34-year-old patient, or my patient with 34 years of chronic pain, he had to have a 5-level lumbar fusion, and that fusion interferes with his movement, and it also causes an impingement of his L5-S1 nerve root on the right. Well, that causes a neurological discomfort with pain and down his back and down into his hip and into his leg. Well, that pain causes muscle tension in his lumbar spine. And because he can't move that spine anymore because it's fused, he's very vulnerable to this vicious cycle of pain, which continues on throughout the day and night. Oh, did I mention it's every day? 7 days a week for 34 years. So what do you do about that? Oh, what does it mean? You're starting to see how complicated this gets? Well, what it also does is causes fear. Nobody likes pain, but on the other hand, we say that no pain, no gain. But this particular pain causes him to get scared because he wonders if it's going to cause him to be paralyzed, because for a while he was after the accident. Well, what does that fear do to his muscles? Causes them to tighten up. Oh, what does that do to this vicious cycle of pain? Now he's scared, so it's now contributing to the tightness in his muscles, which causes more pain, which causes more spasms, which causes more pain, which causes more fear. But then he also gets depressed. What's the most common symptom of depression? Well, sadness. What's next? Well, insomnia. So the less he sleeps, the more he hurts, the more he hurts, the more he gets scared, the more he gets scared, the more you're starting to see this, how it works. So what's important to recognize is that when someone has chronic pain, the comorbidities, the impact on someone's life is so significant and so pervasive that it makes treating that patient in a one-dimensional way extremely difficult. And it's important to realize that the vast majority of clinical care that's provided in our country is very one-dimensional, okay? You go in, you see the doctor, it's just you, it's just the doctor, maybe an assistant, but it's just a one-on-one kind of thing, okay? And that's effective for the vast majority of medical care out there. But for people like my patient that I'm describing, where he has chronic pain that is chronic benign pain, okay, so it doesn't mean he's going to die. He has depression, he has trouble sleeping, he is overweight, he is out of shape, he is frustrated, he is scared. By the way, what pill do you have for all of that? And by the way, what pills work for that? Not much. But that's what he's been given. And so it's very, very difficult for traditional one-dimensional medical care to address chronic pain. And that's why we developed a field called interdisciplinary pain management, because one-dimensional medical care for patients with these interactives and these comorbidities is pretty much of a failure, okay? And I'm going to take a quick sidelight here when we're talking about treatment. The vast majority of more unpleasant nociceptive stimulation is treated with medications. And generally, if it's significant enough, they will be opioids that are prescribed. You will hear all manner of messages about opioids. But what I want you to start off with is this message that's important, okay? Opioids are good. Okay? They're very good. We are very glad that we have them. The number of humans that have terrible injuries that are very happy that we have opioids is amazing. You will find that many medical treatments are not possible without opioids. Okay, but just like all kinds of things, if they're used appropriately, they're effective and useful. But if they're used inappropriately, then they could cause lots and lots of problems, which is why there's an opioid crisis in our country today. So it's important to realize that opioids are good. They are providing tremendous pain relief. They allow us to have surgical procedures. They allow us to recover from all manner of medical issues with much less suffering. And it's important to realize that they've not been around all that long. Only about really widely available about 80 years. So what did people do before that when they broke their leg or they had a skull fracture or some other terrible accident? Well, they suffered. So like most things, again, opioids are very helpful, very useful. But if overprescribed or inappropriately prescribed, they can cause other problems. An example of that. And since we're talking about this particular patient, an issue that we've had to deal with is the fact that he's been on opioids mostly for about 34 years. And that brings in another problem. And that problem is that the way the human nervous system functions, you will find that opioids will build a tolerance in that nervous response. And it's primarily a brain response. And what you'll see is that there's a habituation or an adaptation to that response that occurs relatively quickly. What you won't be informed of as much is a condition that I would encourage all of you to look it up. And that is called hyperalgesia. And what that is a condition where if opioids are ingested consistently and long term, the human nervous system actually becomes hyperreactive to pain of all kinds, not just the chronic pain. So if someone like my patient who has chronic low back and leg pain and has been on oxycodone for 30 some years, if he has to have, say, a tooth extraction or something like that, it actually hurts him more than the rest of us because his body reacts hyper reactive. It's an additional pain. Okay. So hyperalgesia is another common thing that you see in chronic pain. You start to add up all the complications that come along. The only treatment for hyperalgesia is to help someone get off of the opioids and stay off the opioids for somewhere to the tune of 90 days. Now, how in the heck do you do that? All of this stuff came to light by some pioneers that I was fortunate enough to be part of back in the late 70s, early 1980s. Okay. And we were lucky enough to develop a field of medicine called interdisciplinary pain management. And it addresses the concept that you can't have enough clinical impact if you treat chronic pain, a one-shot kind of concept. Okay, that's, the vast majority of clinical algorithms are based on the fact that time has a beneficial impact. Well, there are certain conditions that's absolutely not true. In fact, it's opposite. Malignancies, cancers of all type, left untreated, get worse. Okay. A ruptured appendix, time is not going to help that. On the other hand, when I broke my arm as a kid, they put it in a cast and said, come back in 6 weeks. Well, in that case, time actually was a beneficial impact factor. It actually helped. If you have an infection, you go to the doctor and they say, "Oh, you got a sinus infection. Here, take this antibiotic, and you know, come back in, a couple weeks." Well, time and the medicine will help, and it will kill the bacteria, and it will allow you to feel better and be in less pain. But some things, time is a malignant factor, and one of those things is chronic pain. So, in developing this field, we agreed that we needed to be able to have sufficient clinical impact within a short period of time. And so we developed this treatment team that included a variety of clinicians. We'll talk about those in a second, but the idea was that we were going to use the combination of those treatments and modalities and therapies all together in a very concentrated manner that would allow us to have sufficient impact to address this patient's pain and muscle tension and fear and depression and lack of understanding and not knowing what this pain means. If we could attack that all in a very coordinated and intensive manner, that would allow us to be able to give the patient the ability to control their pain instead of their pain controlling them. Now, that last part is the essence of how you treat patients with chronic pain. We tell them straight up, "I don't think I can cure your pain. I told this fellow, this is my patient. I don't in any way believe that after 34 years I can get rid of your pain. However, what I can do is give you the ability to understand the various aspects of your pain, address those aspects of pain in a very effective manner, and reduce the pain, so that therefore gives you the chance to control the pain instead of your pain controlling you." Does that make sense? Because that's the issue. Interdisciplinary pain management was, I'll give you a bit of a history. In the early 80s, there was no such thing. It's important to realize, before the 1970s, there were just a few people, a guy named Melzak, a guy named Wall, a guy named Bonica, all people that I was familiar with and were contemporaries, and they did a lot of good work, but it was all pretty isolated. So I was asked to join the Greenville hospital system. It's a very large hospital system here in Greenville, South Carolina, with another fella, and we were able to develop what was the first interdisciplinary pain center in the Southeast. Well, I'm sorry, not Southeast. A guy named Rosenwald did one before that in South Carolina. And it grew very large. We ended up taking over 2.5 floors of a 9-story hospital and treated thousands and thousands of patients. We wrote books. We had our own medical journal. And then one time we were actually on 60 Minutes, very small little blurb. But at that point, things exploded and it became very well known. And everybody throughout the country wanted an interdisciplinary pain center. And the reason is because when you think of the patients that I've described with this fellow and the kind of comorbidities and difficulties they have, the results of our treatment are pretty impressive. Our average patient would be in treatment very intensively for about 30 days. And by days, I mean all day. They would start at 8 o'clock and they would finish at 5 o'clock. So treatment would be just one after the other all day long. And that would allow us to then help them achieve results. The average patient had a 276% increase in physical functioning, a 45% reduction in chronic pain, an 85% reduction in opioid intake, and a 60% return to work. And those statistics are not at discharge. Those are 1 year after discharge. So it allowed us to have a tremendous impact. And we proliferated facilities all across the country. As Dr. Kemp mentioned, I'm now working on my 23rd. But I did 22 up until, I guess it was probably 2001, when the opioid manufacturers declared war on us and said they were going to put us out of business. And I had the OxyContin manufacturer, the salesperson, sit in my office, and he said, "Dr. Kriegel, we're going to put you guys out of business." And I just laughed at him. Well, they did. And the way they did it was by eliminating reimbursement for our facilities. And they closed about 3,000 altogether. There was about 40 that survived. And so that actually coincides directly with the opioid crisis. Now, the reason for the hostility was that the definition of interdisciplinary pain management includes the concept that it's the only field of medicine that was specifically created and developed to treat pain with the least amount of opioids possible. Back in the 70s and 80s, we knew that opioids, after a while, your body builds a tolerance. I just talked about that. It also creates this condition that I mentioned called hyperalgesia. So it doesn't mean we don't use opioids. As I said earlier as well, opioids are good. Opioids are good. But with chronic pain, they create a significant danger. So the opioid manufacturers decided they didn't like what we did. And if you think the opioid manufacturers were pretty evil, the answer is yes. Because what they did not only was immoral, but it was illegal. And they lied about the addictive qualities of opioids back in the 70s or back in 2000s. A lot of people have died because of that. I don't know if you are familiar with the statistics, but the opioid overdose deaths in the 70s and 80s was around 5,000 per year. It jumped to 17,900 in the year 2000. Yeah, the year 2000. And last year it jumped to 109,000. So while a lot of that's from illegal drugs, many people started on opioids that were prescribed. So it's important to realize that interdisciplinary pain management is now making a comeback. I am doing everything I can to revitalize the field, and we're making good progress. And any of you that decide you may be interested in being involved with interdisciplinary pain treatment, you will also be somewhat of a pioneer. There's about 40 or so facilities in the country. The facility that I opened in Swanee is actually the only inpatient, outpatient, CARP accredited program in the country right now of that type. Okay, there's others out there, but they're all outpatient. So it's important to see that we have a comeback, and it's working. The requirements for an interdisciplinary pain center are actually not very stringent. It takes about 4,000 or 5,000 square feet. They can be pretty much almost anywhere. Most of the time I put them in hospitals, but I actually put one in a strip mall one time, and actually that one was in Athens, Georgia, and that program did very well. They the first year they treated 411 patients with over 4,000 daily visits in the first year of operation. So it's very, very powerful treatment. The way the layout of the facility is focused is you have to have a pretty big area for a gym. We do a lot of exercise, a lot of conditioning. So there's got to be enough room to have patients in there. And by the way, the key thing about how this treatment works is what's called milieu therapy. Okay, as I mentioned earlier, a lot of the patients, or a lot of the care, pretty much all the care you guys may have received at this point in your life, is going to be that one-dimensional kind of thing, one-on-one with the clinician. It may be a doctor, it may be a physical therapist, or it may be a nurse, but it's kind of one-on-one. What makes this therapy, this treatment approach called interdisciplinary pain management, so powerful is that we treat patients in groups. And that may sound odd, but it is very, very powerful because there's always someone who looks out for the others. There's always the interaction and reassurance that I'm not the only one. Chronic pain is very lonely. When people are hurting all day and they're not working and they're not able to get out and they can't do the things they want to do and they can't spend time with their family, it's very isolating. And that is one of the origins of their depression. So by treating patients in groups, they get this interaction and this camaraderie and this support that they haven't gotten. And it's incredibly powerful. So you have to have areas within the facility that are big enough for groups. Now, the facility I had here in Greenville, South Carolina, there's a reason it was 2.5 floors of a 9-story hospital, and that's because I would be treating patients. My daily treatment numbers would be anywhere from 40 to 60. Now, they weren't in one group. Okay, we split them up in groups of like 15 and alternated, but you have to have enough room. Most of the smaller outpatient facilities, they'll treat 10 or 12 patients a day. So you need to have a gym, you need to have a couple of rooms for like classroom kind of things, because again, a lot of the treatment is education. So you're teaching people, what does pain mean? You're teaching people about the pain muscle tension cycle. You're teaching people about medications and things of that nature. So what you find is that you need some offices, you need a gym, you need a couple of classrooms, you need exercise equipment, you need modalities for PTs, OTs, things of that nature. But it's not like a surgical suite. So it's pretty simple. The requirements and the role of each of the modality or each of the disciplines that work in these facilities, number one is that you have to be a team player. Okay. And that may sound odd, but in medicine, there's a lot of silos. Okay. And people want to stay in their silo. So the idea that, you're going to have a physician and a psychologist, occupational therapist and physical therapist and nurse all working together in a very supportive way, in a cooperative way, a collaborative way. That's unusual. You see it occur in cancer treatment, but you got to realize cancer treatment's one of the other few things in medicine where you get your butt kicked every day. And the challenge of treating patients with complex chronic pain is difficult, and you get your butt kicked every day. And you're always trying to figure out new, better, more effective ways to get these patients better. And so you need that cooperation and collaboration. The initial part of treatment is a required assessment. So patients aren't referred for treatment, they're referred for an evaluation. And they're evaluated by all 5 disciplines. And then afterwards, a treatment plan is developed and is presented to the patient. And if it looks appropriate and they're motivated, then you offer the patient to be treated at the facility. The physician's role is to, what I usually tell my medical directors is, you need to make sure we don't make any of these patients worse. That's the top thing, because they have all manner of medical issues. And example of that you've got to be aware of is, if somebody's out of shape, overweight, what's the chances that they have diabetes? What's the chances they have high blood pressure? What's the chances that they have other issues that they're having to deal with? Well, it's the medical role to make sure we care for all those different aspects. And also we evaluate the patient to determine if there's anything else from a treatment standpoint that would be more effective medically for this patient. The physician also oversees the medication withdrawal. Obviously, we want people to control their pain with the least amount of opioids possible, but also other medications. We want to have them on the least amount that we can. The psychologist role is really, really big. It requires, and by the way, for all of these disciplines, it requires a tremendous amount of additional training. You don't get the easy patients. The average patient that I see has been evaluated and treated by somewhere between 7 and 9 doctors. And if they're in my office, all those people failed. So you got to realize that they've been tried on all kinds of things, and it ain't worked, or they wouldn't be dealing with chronic pain. So you have to have CRPS, lumbar pain, spinal or cervical pain. You know, I have patients sit down in front of me that they have a herniated nucleus pulposus at L5S1 on the right. You have to know what that means. What's the cause of complex regional pain syndrome? Well, it happens to be an overexcited autonomic nervous system. You have to know what that is, and you have to be able to explain it to the patient, and you have to know what to do to treat it. How do you effectively withdraw patients that are taking? I have a patient that we treated at the Reiser Center, was referred to us. He was on 240 milligrams of OxyContin per day. If any of you took that much in a day today, you wouldn't wake up. And he'd been on it for 7 years. How do you withdraw somebody from that? So I'm just trying to illustrate that it's the complexity and the interactive nature of these patients requires a tremendous amount of additional training far beyond what occurs in the traditional tracks. So that's why I've complimented Dr. Kemp tremendously. She is a hero in my point of view, because she spearheaded the chronic pain program at Mercer, which, as best I can tell, and I'm very familiar with most all the top medical schools in the country, as far as I can tell, Dr. Kemp and you guys are it. I can't find anybody else. Stanford, this fellow I know out there, and there's a guy that teaches some classes. Ravi Prasad is a friend of mine. He's at Berkeley. But no, now I'm trying to get a lot of them up and going. But right now, you guys are the champion. The psychology aspect of chronic pain is enormous. I'll tell you one quick story. I had a patient that came into my office, had chronic back pain for a long time. In my assessment, I always ask, and so how was your childhood? And she looked at me real funny, and in this strange voice, she said, fine. And I thought, oh, I've seen this movie before. So I waited a little bit, and then I said, did you grow up around here? And you know, how was it growing up? And she again looked at me real funny and said, I said it was fine. And you think I'm kidding, but I'm not. At that point, I said, well, by the way, did your father ever hit you? And she said, no. And 4 red marks came up on the right or left side of her face. And I said, huh, your father was right-handed. And he wore a big ring on his right hand, didn't he? And she said, yeah, how'd you know? The autonomic nervous system is largely controlled by the amygdala. The amygdala stores trauma memories. If you have any interaction or involved in any way treating patients with chronic pain, you will be astounded at the number of trauma victims that end up with chronic pain. The vast majority of those come from child abuse. It's my experience is it's probably 40% of all the people that suffer from chronic pain. And that number of chronic pain victims in our country varies an estimate from 20 million to 50 million, but it's a lot. So the psychology aspect of this is enormous. Occupational therapy is all about functional restoration, helping patients get back to their way of living, way of life, in spite of their pain. Okay. And so, activities of daily living, how to do this without harming yourself, how to do this without making your pain worse, all become issues that the occupational therapy folks have to deal with. And again, what does that pain mean? Physical therapy, one of the best things about the role of the physical therapist is that they get to practice, and the occupational therapist as well, as they get to practice some psychology. And the reason that's so important is because their interaction with patients in the gym and in the classroom and things of that nature allows them to provide not only the education, but the reassurance and the essential understanding of how to move, how to do things, and not cause yourself to hurt more. Nursing is the oversight group that makes sure that we don't do anything on a day-to-day basis that's going to harm the patient. They also oversee the medication withdrawal. They also provide a lot of the educational components. So they're kind of the glue that holds everything together. And I'm going to stop there because I think we were going to try to have allow a little bit of time for questions. But I hope this was helpful. And the number one takeaway that I wanted you to see is how effective this treatment approach is when provided in the right place, in the right way, by the right clinicians. And we're resurrecting this field right now. And I think you guys, again, I want to thank Dr. Kemp for being willing to also be a pioneer in this field. So with that, I'll see if anybody has questions.
I think you did a very good job bringing that point across. I'm excited about this field. I'm wondering, could you talk a little bit more about how each of those team members communicate with each other? You said the patients are there sometimes a full day, but over time they're there for multiple days. So, does the team members communicate with each other about the progress of the client? Is it daily? Does the client or the patient know where to go after each session? Just kind of like how the day kind of works, like, and how we all can be a part of a patient's progress and communicate with each other.
Very good question, and I appreciate it. The communication is required. It is the fundamental foundation of the care that's provided, and the team is a team. Okay, so in other words, each of the clinicians function within that team. They're not in the PT department. They're not over in the nursing department. They're part of this department, so they're dedicated. Here in Greenville, I had 82 employees, and they all worked directly under my supervision. And they were nurses, PTs, OTs, psychologists, physicians, and they met every morning. We had a morning rounds, and the patient day varies depending on the need. But the more severe chronic pain patients, they start at 8 o'clock, and they have treatment therapy all day long. Okay, and they'll do that if it's an inpatient 7 days a week. If it's an outpatient, 5 days a week. But then what the clinicians do is they alternate with the patient. So if you said, what does a patient day look like? Okay, it starts out with warm-ups led by the psychologist, who then, while during those warm-ups, not only does that person get to exercise a little bit, but it allows the psychologist to assess the patients. That's followed by physical therapy. That's followed by relaxation therapy, which is followed by lunch, which is followed by occupational therapy, which is followed by pain school, which is followed by group therapy, which is, so you see, all day long. Does that make sense?
Absolutely. And I think all those aspects are so important. It tackles everything that the
Yeah.
patient could need. Yeah. Thank you.
there's a hand up. I don't know what that means.
Um, yeah. So I had a question for you, Dr. Kriegel. My name is Janelle.
Hey,
Um,
Jeanette.
yeah. So I'm sure that throughout your career, you've dealt with a copious amount of patients, meaning you've come across different cultures and races. And I was kind of wondering if you ever noticed a difference between clients in different races in the way that they deal with chronic pain, and if you have seen like the importance of culturally competent care.
I think there is absolutely a difference in the way cultures address pain from the standpoint of understanding. Okay. And so if you said, well, is there, one of the aspects of this discussion that I didn't get into that we need to, if we do some of these again, is how to measure pain. Okay. And so when you look across races and you say, okay, how do we measure pain? That's influenced tremendously by different social aspects. Okay. So if I said, can you give me a pain rating on a scale of 1 to 10, 1 being, very little, and 10 meaning we got to go to the emergency room. If you're talking to someone who doesn't understand that concept very well, you're not going to get a consistent response. Okay. And so a lot of the differences that you run across from a social standpoint or a cultural standpoint, they're big, and they start with that ability to communicate and that ability to understand what their pain means. There's other cultural differences, and again, that's a huge topic. But just to give you an idea, there are certain cultures that pain is something you're supposed to ignore, and you're not supposed to talk about it. You don't mention it, and so yeah, there's some really big differences, and you have to, again, we treat patients in groups, but every patient has to have an individual treatment plan that is implemented specifically for them and their condition and essentially who they are. That's one of the more important aspects of interdisciplinary pain management is one size doesn't fit all. You have to have a very individualized treatment, and that's based on that person.
Thank you.
We'll conclude one more question.
Yeah.
Hi there. Hear me?
No, I didn't.
Can hear you a little bit now. Go ahead.
Okay, what about now?
Yes.
Okay, perfect. I have a question. I'm actually in the clinical mental health program, and so I'm really interested in how you started off your presentation with talking about the relationship and how people perceive emotional pain versus physical pain. And I'm just curious to know, like, when people show up in your facility, does it manifest differently, I guess, in terms of how you can notice the difference, or could you draw the conclusion that basically emotional pain and physical pain kind of show up similarly when the client presents?
Yes, all of that. Again, I'm being smart aleck here because there's so many different aspects of it that you have to be able to understand. The patient that had the red marks on her face that looked like a hand had been severely abused as a kid. So, did that influence her chronic pain? Yes. Did that cause her autonomic nervous system to be out of control her entire life? And did that interfere with her body's ability to heal? Yes. All the above. Okay. The most important aspect for someone that's, if you're looking to get into this field, the most important aspect of it is to have a broad enough understanding of the psychological components of related to pain, but also the physical components, because you have to be able to sort it out. If you guys know what a clinical algorithm looks like, it's this pyramid, okay? And I tease the different surgeons I work with all the time when I tell them, your clinical algorithm looks like a stick. You have just a few things, yes, no, and you just follow that algorithm. Because I have to look at all of those physical things, all of the psychological things, and the interactions of those. My pyramid, my algorithm looks like this. So it's that it's you have to really have a very broad understanding of all manner of physical and psychological components to chronic pain.
Thank you.
Okay, I know we have a couple more questions. Yvonne, well, what I'm gonna do is I'm gonna say I'm going to do a soft close, and then those who want to stay on for additional questions, Dr. Kriegel, if you're available for a few more minutes to
Yeah,
take additional questions, that would be great. But I want to start off by thanking everybody for attending. I want to share the QR code to provide feedback. You can use your phones, or you can click on the link that's in the chat. We'd love to hear from you. You also will get a survey link sent out to you later. So I will say a formal thank you, but then we will turn it back over for a few more questions, because I did see a question in the chat, and I know one of our pain scholars has a question as well. So thank you so much for this conversation, Dr. Kriegel. We really appreciate your insights, and just from your history working in the field. This was an invaluable presentation. I know many folks on here were enriched by your perspective. So thank you again. And if you have to drop off, feel free to, but if you can stay around if folks have questions, go ahead and stay around.
I can stick around. Yeah.
Okay. Thank you. All right, Yvonne, go ahead.
Hi, I just wanted to say thank you so much for this presentation. And you kind of spoke to this a little bit already, but really part of it sounds like what has helped you be a pioneer in this field and in this subspecialty is sort of bringing alive the idea of holistic psychology and really approaching each client with, really where they're at, but kind of by all means necessary. So bringing in people and all of their specialties too, and how it could help them. And so I'm wondering if you have already brought in or are considering bringing in any CAM alternatives, like alternative or complementary medicines, into your pain management practice.
Absolutely. Earlier I mentioned that in this field, if you choose that you want to be a part of it, you will get your tail kicked every day, and that's not kidding. And the reason is because it's so challenging. And so what I tell everyone is we don't have the luxury of throwing away tools. If there's something that will help someone improve the control of their pain and improve their life, we have to consider it. So we don't outright reject anything. Okay. Now, my perspective is that I have always lived by hardcore science, and the publications that we've done, the research that we've done is hardcore. It's very, very stringent. So I just ask that, if somebody says, well, can we include fill in the blank? Okay. My first response is, okay, let me see the science. Let me see the research. And Yvonne, that's challenging because the field was really growing and really including a lot of different treatments, modalities, you name it. And then we got squashed by the opioid manufacturers. So we're in the process of trying to evaluate that. And some examples are, I would love to be able to have chiropractic as a part. I think yoga is very valuable in a lot of different ways. But those are two examples of things that individually I think can help people significantly. But the inclusion of them in a daily treatment regimen, like what we've described here, is not researched. I can, those 5 disciplines, I can show you hardcore research that proves that they're effective and helpful with patients with chronic pain. But I can't do that with yoga, for instance. I can't do that with chiropractic. I can tell you, I think, but I won't live in that world. The patients we treat, they are trusting us to treat them effectively, and so we can't just guess. But I will tell you that my hope would be that as we revitalize this field, that we're able to do that And in fact, I've published a paper that I sent to Dr. Kemp on the evolution of interdisciplinary pain management from multidisciplinary to interdisciplinary to transdisciplinary. And so it's coming. And I think there's a lot of things I'd like to include, or at least, research and evaluate whether or not they would be powerful enough to be treated. One of the more important aspects of that is going to be the implication and effectiveness of this right here, some sort of, health treatment, health management, pain management over the internet. How effective is that? And so we need to, I think we need to try it. We need to incorporate it, but we need to make sure that we can tell our patients it works. That was a long answer. Sorry about that.
No, it was excellent. You answered it very well, so thank you. I appreciate it.
I did see a question in the chat from a participant who asked if you could, they said you have done a wonderful job covering interdisciplinary aspects of care. Thank you for sharing. Questions. First one, can you speak briefly on multimodal pain management in terms of non-opioid medication and helping patients? And two, what is your go-to reference for medication management of pain?
Well, actually, we did some research back in the 80s. I'll share this with you. It's and I would encourage you to try it. The research was on over-the-counter medications, and we found that if you have 800 milligrams of ibuprofen, no matter whether it's a single dose, which is 800 milligrams of ibuprofen is the prescription dose of ibuprofen. Over-the-counter ibuprofen is the same as prescription. It's just prescribed in 200 milligram tablets. So 4 over-the-counter tablets of ibuprofen is the same thing. If you take those 4 tablets of ibuprofen at the same time that you take 2 tablets, or essentially 1,000 milligrams of acetaminophen, we found that it had the same pain relieving effect as 30 milligrams of codeine. It's obviously much cheaper. Obviously, it's not addictive. Obviously, it's readily available, and it works. So you can take it 3 times a day, and you can take it off and on, or as much as you need for a very long time, as long as you don't have any stomach irritation from the ibuprofen. I don't remember all. Did I answer that question or not? Because you said the go-to. That's one of my number one go-tos. Multimodality care. I'm not sure what it was the question about various treatments.
I think you covered the question. If the person wants to do a follow-up, I'd encourage them to do so. I'll add this follow-up question, though. You mentioned the OxyContin industry blocked the ability to be reimbursed. Has that now changed? And is the reimbursement as good as prior to the blocking previously? I know that's something you're working really closely on, so I wanted you to get a chance to speak to that.
Yeah, thank you. Yes, resoundingly yes. A couple examples are we do have a contract with Aetna. We're in the process of working on a contract with Anthem, or Blue Cross Blue Shield. I was this is hot off the presses. I was asked recently to do a data analysis on one of the largest employers in the state of Georgia, and they have 700,000 employees. And they wanted to identify how many patients or how many people out of that 700 had chronic pain. And so we did an analysis and found that out of the 700,000, there were 11,800 in 2023 that were diagnosed with chronic pain that were taking at least one opioid. And so then I asked, okay, what is that costing this employer? And it turned out that in 2023, those 11,800 people cost this employer $428 million. And I said, that can't be right. So we ran it again. And I said, it can't be right. And we ran it again, came back to the penny. And so I said, well, that maybe it's an anomaly. Let's look at a broader range. So we looked at 6 years, okay? And the same 11,000, the cohort of 11,000 accounted for an average of $430 million per year for 6 years in a row, for a total of 2.5 billion. Now, that is going to get us a lot of leverage with the payer sources. This year, for the first time in 20 years, Medicare actually published an interdisciplinary pain management treatment policy. Blue Cross Blue Shield has the same. This employer that I'm talking about is going to give us the data. We're going to be able to publish that hopefully in the next few months. And we're going to do a comparison with treatment at a friend of mine's IPM program in Southern California. So we'll be able to have an actual experimental model that we'll be able to publish. So yes, we're working on it. It's not there completely, but the fact that Medicare actually published this policy tells you that it's there. We just have to, the key thing is that to provide the treatment like we've described daily, you have to be paid in a daily way. You can't be paid by CPT codes, okay? Because it just, you can't make it work. So what we ask for is a per diem or daily rate, and that's what we're working on now with Medicare.
Okay, let's see. All right, I'm gonna propose we take one more question since we're about and to respect Dr. Kriegel's time. I appreciate you willing to stay on a little longer. And maybe what we can do is consolidate additional questions and send those over to you. Let's go with Abby.
Ooh, no pressure, last question. Well, first of all, thank you, Dr. Kriegel, for sharing all this information with us. I think it's been really insightful as someone who's interested in maybe going into this field. What I wanted to ask you was kind of going back to Yvonne's question about alternative medicines and maybe less researched, less hard sciencey things like mindfulness, yoga, and those types of practices for treatment of chronic pain. I wanted to see if you could speak to any ongoing research that your pain management clinics are doing into those types of potential treatments for chronic pain, and if you are, like, if there are any opportunities for students like us to be involved in that research.
Not at this moment, Abby. We've got several projects that I'm working with a variety of folks at Mayo and Johns Hopkins and different places. We've got several research projects we're working on right now, but I don't have anything at the clinic that's there in Georgia right now. But certainly would be interested in involving you in anything that we would start there. But let me bring up one thing that is a huge topic, and maybe if you guys want to do this again sometime, we can make this part of the discussion. The single, because it always revolves around the alternative medicine concept, okay? And you guys got to be very, very aware of this. The single most powerful treatment modality actually is involved in every research study and is involved in any kind of clinical care. And that treatment is called placebo. And some friends of mine and I have actually published some research. One guy's named Dr. Williams has published a very elegant article describing the role that placebo plays. And it's important to understand that placebo is the patient's beliefs about the treatment. And in actual fact, that is proven to be as powerful or more powerful than many actual clinical treatments. So that's one of the issues that you run into, is that you have to do comparative research in pain management in order to understand, is this treatment, whatever it may be, is it actually clinically effective or not. And you know, how much of the effect is placebo? And you know, it's a really powerful issue. An example is a research study I was reading earlier this week on blood pressure, that they were, you know, evaluating a new blood pressure medicine, and uh, the placebo group had a 34% improvement in their blood pressure. How does that happen? How does that? I mean, they were taking a pill, looked just like the same pill that the other people were taking, but it was inert. There was no, you know, true clinical impact. But how did their blood pressure in 34% of the people involved in it? How did 34% get better? So that's one of the things you run into with alternative treatments, and you'll see all manner of things that are on TV about, you know, take this or take that or this herb or that whatever, and it'll make a difference. Unless you can do comparative research, it's hard to be able to say for sure that it works or doesn't work. The key thing to understand is that when a physician prescribes a patient with diabetes, if he or she prescribes insulin, it has to work. And it has to work with every person the same way. So there was St. John's wort is a good example. For decades, people have thought that it was a really good, effective treatment for depression. And you know, oh my gosh, it took this, and 2 days later, I was, you know, singing for joy. I mean, you know, all this kind of, you know, individual support. But when they did the comparative research, it failed miserably. It was actually less effective than placebo. And a lot of the current antidepressants, the clinical effect will be 50%, 52%, and you'll get 30, 40% placebo effect. Well, do you want to pay? I mean, I'd rather buy the sugar pill. you know, I mean, it's cheaper, and there ain't there's no side effects. So when you get into, you know, these types of questions, it gets real sticky, especially when you say, okay, I'm going to involve this treatment as a modality within my interdisciplinary pain program, but how do I get a placebo group? How do I tell X number of people we're not going to treat you? So you get into, it's really a tangled situation. The exciting thing is that I'm leading a study right now with a friend of mine who's got a program that I want to mention in California. And we're attempting to take, I mentioned this employer that has 700,000 people. Okay, well, we're going to take some of those patients, some of those employees that are in that 11,000 group, and they're untreated. Okay, they have not been treated with interdisciplinary pain management. So we're going to use those as our comparison group, or essentially our placebo control group. Okay, and we're going to be able to compare directly. We've got about we're probably going to only use 250, but we got up to 8,000 that we can compare it to. So that will allow us to actually get a real true experimental study with a control group. These questions don't, I can't, they're
No, I appreciate you answering.
They're very good questions, and they're not yes, no answers. They're lots of parts to it.
Yeah, absolutely. Well, I appreciate you answering, and I think you brought up some really good points and challenges to that type of research. So I'm excited to see where it goes in the future.
Yeah, we're going in the right direction. I think it's all going to be good for the country in the long run, but it's been a challenge up until recently.
Yeah, I appreciate, and I think we all appreciate the many multifaceted components related to addressing chronic pain management, from the particular clinical level all the way up to the policy level, and recognizing that it's not this is not an issue that any one discipline can solve in and of itself. And so I think as part of the chronic pain management program in the College of Health Professions, I think we gravitate towards in integrated healthcare model, and we're part of the Health Sciences Center at Mercer University that covers a wide range of health disciplines. And so on behalf of us here, we just want to again thank you, Dr. Kriegel, for your presentation. Found it fascinating and informative. And so we look forward to continuing to talk with you further. I'll consolidate some of these questions and send them over to you. And thank you everybody for joining and for being so engaged on what has become, well, it was a snow day on the Atlanta campus and became a snow afternoon on the Macon campus. So wherever you are, stay safe and warm, and thank you again.
Thank
Bye.
you. Bye-bye.
Take care, guys.
Bye-bye. All right. You can go ahead and end the meeting.